Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
This is our first episode on radiation oncology for gynecologic oncologists. Today, we're going to be discussing the fundamentals of radiation therapy. Sydney, what are our learning objectives for today?
Our learning objectives are to understand the biology of how radiation works, recognize how fractionating a course of radiation improves the therapeutic ratio, to develop a general idea of radiation dosing for gynecologic cancers, to identify the different types and subtypes of radiation administered for gynecologic cancers, and lastly, to understand the general principles that guide use of brachytherapy in gynecologic cancers. Let's get started.
Make sure to check out our website during or after listening to this episode, as we put some helpful figures there for your review. Radiation is something that we as gynecologic oncologists won't personally be delivering, but we will have many patients who need radiation as part of their therapy. So it's important for us all to understand how and why radiation is used in the treatment of our patients. Sydney, can you tell us how radiation works to damage and kill cells?
Ionizing radiation works to kill cells mostly via DNA damage, resulting in double-stranded DNA breaks, which are responsible for cell death. Ionizing radiation waves are high frequency with short wavelengths, most commonly photon therapy. High-energy photons from the radiation waves collide with tissue, depositing energy into the tissue and ejecting electrons from the atoms, generating ions. This is called the Compton process. Ejected electrons then mediate the tissue responses via either direct or indirect effects. 75% of tissue damage from ionizing radiation comes from indirect effects, where electrons interact with water atoms to generate hydroxyl radicals, which then create oxidative stress and DNA damage. The remaining 25% of radiation damage comes from direct impact between scattered electrons and DNA. The photons that collided with DNA get scattered with less energy and can continue to interact with the other atoms, ejecting electrons until they no longer have energy to accomplish this effect. Maya, then what happens to the cells after they experience this DNA damage?
Cells will attempt to repair the damage via homologous recombination or non-homologous end joining. Inaccurate repair, resulting in chromosome and chromatid abnormalities, often occurs via non-homologous end joining. The most common way that radiation induces cell death is through mitotic catastrophe. The inaccurate repair means that when the cell attempts to divide, it will die, undergoing mitotic cell death. This is a form of reproductive death. Mitotic catastrophe results in necrosis and inflammation, which shows up when the cell attempts to divide. This means that radiation effect is not limited to the time of therapy, but that cell-killing effects last until the next cell cycle when the cell attempts to divide, which can be a few months after radiation is delivered. As in chemotherapy, tissue response to radiation follows a log cell kill model, where each dose or fraction of radiation kills a fixed percentage of cells. Sydney, can you tell us how we use this log kill principle and radiation biology in general to structure our delivery of radiation?
Of course. Fractionating radiation doses alters cell kill, requiring a higher dose overall to reach the same amount of cell kill. Both rate of delivery and total dose matter for radiation effect. When planning doses of radiation, we are attempting to optimize our therapeutic ratio, which is the ratio of the amount of radiation needed to cause desirable effect/sufficient cell kill, the tumor control probability, compared to the toxic effects of radiation, normal tissue complication probability. Fractionating radiation doses does improve our therapeutic ratio. Factors that impact a tissue's sensitivity to ionizing radiation and explain the rationale of using fractionated therapy have been described as the 4 R's of radiobiology: repair, repopulation, reassortment/redistribution, and reoxygenation. Repair refers to repair of DNA damage, which we've discussed a little bit already. Different cells repair DNA damage at different rates. Normal tissue cells, which have intact DNA repair mechanisms, are more able to repair radiation-induced damage than cancer cells, as cancer cells tend to have more aberrant DNA repair mechanisms. Fractionating a course of radiation with doses at set time intervals ideally gives the normal cells enough time to repair themselves, while the cancer cells won't have a chance to complete their DNA repair prior to the next fraction.
Redistribution refers to redistribution of cells in the cell cycle. Certain portions of the cell cycle have more ability to repair DNA, meaning more resistance to radiation. Cells are most radiosensitive during the late G2 and mitosis phase, while the S phase of the cell cycle is the most resistant. Homologous recombination can only be done when there is a DNA template. If we irradiate a cell when the only type of repair is non-homologous end joining, then the cell is more likely to have errors in replication and subsequently die. In any given tissue, a proportion of the cells will be in more and less sensitive portions of the cell cycle. Ideally, in the next fraction, we'll catch the cells that were previously in a radioresistant cell phase, like the S phase, and are now in a radiosensitive phase, like G2 to M. Repopulation of tumor cells between fractions can decrease the efficacy of our ionizing radiation. After radiation is delivered, tumors tend to undergo accelerated repopulation due to stress response and a proportion of the tumor dying. This is why we want to avoid treatment breaks and treatment delays. We want to minimize the overall time in which the total radiotherapy package doses are delivered. Cervical cancer is a good example of this principle clinically. Patients that have a prolonged time of radiation delivery have worse outcomes. Some studies suggest that rates of pelvic control may decrease by nearly 1% per day when treatment extends beyond 56 total days.
Oxygenation of tumor cells alters sensitivity to radiation. In hypoxic conditions, cells are relatively resistant to radiation. The dose of radiation needed under hypoxic conditions is 3 times that needed in oxygenated conditions to have the same cell kill. As tumor cells die, there's less competition for nutrients, and thus surviving cells become more oxygenated, which provides more substrate for free radical formation, making them more sensitive to radiation in the next fraction. Maya, how does combining radiation with chemotherapy enhance the effects of radiation?
In certain disease sites, we use radiosensitizing chemotherapy to enhance the efficacy of radiation. Cervical cancer, again, is an excellent example. Radiosensitizing drugs increase tumor sensitivity to radiation therapy, and some drugs actually preferentially radiosensitize tumors over normal tissue, further improving our therapeutic ratio. Radiosensitizing chemotherapies like cisplatin tend to arrest cells in mitosis, making them more radiosensitive. Additionally, radiation and chemotherapy kill cells in different ways, so combining the two can help prevent the development of resistant tumor clones. Other targeted therapies that have promise as radiosensitizers include bevacizumab, EGFR-targeted therapies, and immune checkpoint inhibitors. Improved radiation sensitivity can be a double-edged sword. Too much radiosensitization can worsen toxicities from radiation therapy, and certain chemotherapies can even trigger radiation recall, as we discussed in episode 7, chemotherapies for uterine cancer. Okay, we reviewed radiation biology, which impacts fractionation and dose of radiation. Sydney, can you tell us about some of the physics that round out our understanding of dosing of radiation?
In gynecologic oncology, the majority of the radiation that we use is photon radiation, as previously discussed. Photons can come from nuclear decay or from particle acceleration. Particle acceleration accounts for about 95% of radiation that we use, and this is mainly used as external beam radiation. Linear accelerators are used to convert electronic energy in the form of electrons into X-ray, aka photon, radiation. Electrons are accelerated and then rapidly decelerated, which turns the kinetic energy into electromagnetic radiation in the form of photons. This is called the Bremsstrahlung reaction. So, linear accelerators accelerate electrons to produce photons, which we use for ionizing radiation. The other 5% of radiation that we use comes from nuclear decay. This is used in brachytherapy and gamma knife radiation. A radiation source decays by releasing a beta particle, i.e., an electron, from the nucleus, eventually producing gamma ray radiation, which is a photon. In high-dose rate brachytherapy, the most commonly used source is iridium-192. Maya, how do we measure delivery of radiation?
We usually talk about radiation delivery in terms of gray. 1 gray of radiation is equal to 1 joule per kilogram. A gray is a measure of the absorbed dose of radiation, not of effect, so different energies and types of radiation may need more or less radiation production to deliver the same gray or absorbed dose. 1 gray is equal to 100 rads or 100 centigrade, which is a term for radiation that we don't really use anymore. And 1 centigrade is equal to 1 rad. For many GYN cancers, we deliver 40 to 50 gray for microscopic or low volume disease, and will need higher total doses for gross disease or for positive nodes. Earlier, we described that fractionating our total radiation dose increases our therapeutic ratio. Fractionation of radiation describes how the total planned dose is split up and delivered, and this varies by type of radiation, disease site, and disease characteristics. Most GYN cancers treated definitively or adjuvantly with radiation use conventional fractionation, in which each fraction of radiation delivers 1.8 to 2 gray of radiation. This schedule helps decrease late adverse tissue effects from radiation. Sydney, can you tell us about target volumes for radiation?
Yes. Let's review some definitions that will help frame our discussion of radiation dosing. The gross target volume, abbreviated GTV, is the volume of the tumor that we are targeting based on what we can see with clinical exam and imaging. The clinical target volume, CTV, expands that to include areas that are likely to harbor microscopic spread. We use knowledge of patterns of growth and spread for different disease sites to help define this. For example, lymph nodes or adjacent or margin tissues. As we all know, tissues shift, patients move, and the body is not a static object, so it's impossible to only target or deliver radiation to our GTV and CTV. For this reason, a planning target volume, PTV, is defined for each radiation treatment. The PTV expands the CTV slightly to account for uncertainty in organ position, expected motion, and variation in tissue location, in order to not miss target tissues. This PTV is the final volume used to plan and conform radiation dosing, and it aims to minimize radiation to surrounding normal tissues, also termed organs at risk, OAR. Maya, can you tell us about EBRT, the most common type of radiation used in GYN oncology?
Yes. So based on the above treatment volume definitions, radiation oncologists plan their delivery fields. Imaging with PET, CT, or MRI is used to help planning. Patients are usually immobilized in the same place every time they receive radiation, and often daily image guidance will be used when delivering radiation to optimize delivery each day. This process is very complicated and is beyond the scope of this podcast. We're very grateful to work with our radiation oncologists. Delivery of EBRT is all designed to optimize the therapeutic ratio, and methods to do this have improved over time. Radiation dose and intensity for delivery to a target decrease with distance from the source due to inverse square law and tissue attenuation. A single photon beam isn't an ideal technique because more proximal tissues like the skin will get really high doses of radiation as the beam travels through the tumor. Fluence or flow is a concept which refers to the intensity of radiation or the number of photons passing through the area. Modifying fluence by using a beam modifier, the most simple example is a wedge of lead, allows less photons to pass through the thicker parts of the wedge and allows you to deliver beams from multiple angles. Using opposing beams can also improve the ratio of dose at depth versus at the surface of tissue, delivering concentrated dosages to desired areas and sparing normal tissue. The higher the number of beams that you use, the more the normal tissue gets exposed to radiation overall, even though each section will get a smaller dose of radiation. Sydney, how has radiation delivery changed over time?
3D conformal RT was developed as a way to improve the therapeutic ratio by addressing fluence. In 3D CRT, Hounsfield units on CT scans are used to calculate dosages and to better optimize the view of anatomy. Then, a computerized dose calculation is able to adjust beams and customize the 3D shape of the tumor, optimizing dosing compared to traditional radiotherapy. 3D CRT is limited by a small number of beams, but is simpler and quicker to plan than more advanced techniques, and is still used in some scenarios, like for urgent delivery of palliative radiation for symptom control. Intensity modulated RT, known as IMRT, is a further refinement of 3D CRT and still uses Hounsfield units on CT for dose calculation. IMRT is able to change the intensity of radiation in different parts of a single radiation beam during treatment and uses more radiation beams, which lets us treat multiple areas in the target to different dose levels. IMRT still results in normal tissue receiving radiation doses, although they may be low doses, and so toxicity and long-term complications do still occur. Multi-leaf collimators are devices within the linear accelerator made of tungsten leaves which shift rapidly to match the shape of the tumor as the beam rotates around the patient. These create a customized opening to allow photons to pass through, hugging the tumor edges to protect normal tissues. Image-guided RT allows the use of real-time imaging of the treatment target in normal volumes on a daily basis. Several studies have demonstrated improved toxicity in patients receiving IMRT compared to standard RT, while conserving good oncologic outcomes. The TIME-C study, published in 2018, compared IMRT to standard 4-field RT in 278 post-hysterectomy patients. Patients had much improved GI and urinary toxicity with IMRT. In 2014, Verma et al. Evaluated dose-escalated IMRT to the periaortic tissue and demonstrated improved duodenal toxicity. Young et al. In 2022 also reported improved chronic GI and urinary toxicity in patients with endometrial and cervical cancer using IMRT. Volume modulated arc therapy, VMAT, is an advanced type of IMRT which delivers radiation in 360-degree arches. Maya, so how does stereotactic body radiotherapy fit into this overall picture?
SBRT is a form of focused EBRT, which allows us to deliver high doses of focused radiation to isolated disease sites. This type of radiation is helpful for oligometastases. Typically, these are delivered in 1 to 5 fractions, with a higher dose given in each fraction. Because of the extremely high doses, immobilization and reproducibility is even more important than in traditional EBRT. The SABRE COMET trial was a phase 2 trial evaluating efficacy of stereotactic ablative radiotherapy, abbreviated SABR, which is another name for SBRT, as a primary treatment option for oligometastases. They enrolled 99 patients with solid tumors and 1 to 5 metastatic lesions, all of which had to be amenable to targeted radiation. Patients were randomized to palliative standard of care therapy, which included chemo and palliative symptom-directed radiation, versus standard of care and SABRE to all lesions in the experimental arm. With an average of 51 months of follow-up, the 5-year overall survival was 42% with the addition of SABRE, compared to 18% in the control arm, which was statistically significant, and quality of life was not negatively impacted. This was the first study to show an overall survival benefit to ablative therapies of oligometastatic disease. Let's shift gears and talk about brachytherapy. How does delivery of brachytherapy differ from EBRT?
So remember that brachytherapy has a different source of radiation, which is nuclear decay coming from intrinsic radioactivity of the source. Brachytherapy is delivered to the cervix or the vaginal cuff using applicators. It's internal radiation as opposed to external radiation seen with EBRT. Placement of brachytherapy applicators requires sedation. This is done in the OR or in a procedural suite, often using a combination of sedation and regional anesthesia. The applicators are often tandem and ovoids, also known as a Fletcher application, but can also be a vaginal cylinder or syed templates with interstitial needles implanted through paravaginal and parametrial tissue. The radiation source is housed in a machine called an afterloader, which is connected to the applicators via catheters. The radiation moves from the source down the catheter into the applicator and then into the patient. The applicator guides the radioactive source to the proper position and ideally provides space between the radiation and normal tissue. In brachytherapy, radiation was typically measured conventionally by point A, which is a point 2 centimeter from the top of the ovoids along the tandem and 2 centimeters laterally. We'll put a picture on our website. This is typically where the uterine artery and the ureter cross. The dose distribution will depend on the shape of the applicator and how long the source spends at different locations, i.e., dwell positions. In current practice, radiation oncologists use volumetric-based planning to target tumor and spare organs at risk. Brachytherapy is the most conformal type of radiation with the least dose spillage to other organs. Maya, can you tell us about dose rates for brachytherapy?
Brachytherapy can be delivered via high dose rate or low dose rate systems. At low dose rates of radiation, cell killing occurs by a single electron, which causes double strand DNA breaks. High dose rate radiation can have DNA strand breakage by either the same electron breaking two strands, which is more common at lower doses, or by two separate electrons breaking the two DNA strands, which is what dominates at higher doses. The cell kill curve for HDR radiation is linear quadratic, with more damage occurring at higher doses. Low dose rate brachytherapy was traditionally used, and it requires inpatient hospitalization. High dose rate therapy is now feasible and allows for outpatient treatment and decreased radiation exposure. Both types require shielded rooms for radiation delivery. In a retrospective study by Ferrigno et al., 2005, use of LDR and HDR in cervical cancer were compared. This study demonstrated that in early stages, there was no difference in PFS or OS. In stage 3 disease, there was better OS and disease-free survival in the LDR group, but the 5-year probability of rectal complications was doubled in the LDR group. The authors of this study posited that the HDR dosages were too low. The EMBRACE study, published in 2021, was a prospective cohort study evaluating the use of MRI-guided brachytherapy for locally advanced cervical cancer amenable to curative treatment. Patients were treated with chemoradiation, including MRI-based image-guided brachytherapy. The authors reported a 5-year 92% local control rate, with relatively low rates of severe toxicity related to delivered radiation, indicating safety and efficacy.
That's all we have for you today. We hope we've given you an understanding of the basics of radiation oncology on today's episode of Ready, Set, GYO. Here are your key takeaways from today's episode.
Radiation most commonly induces a mitotic cell death by irreparable damage to DNA. In photon radiation, which is used in EBRT, 75% of damage is indirectly caused by free radicals formed by ejected orbital electrons, and 25% is due to direct damage of the photon itself.
The 4 R's of radiobiology include repair of DNA damage, redistribution of cells in the cell cycle, repopulation of cells between fractions, and reoxygenation. The therapeutic ratio is the ratio between the probability of a radiation-induced complication in a normal tissue and the probability of tumor control.
Radiation dosing is measured in gray, which is used to describe the absorption of 1 joule per kilogram of matter. 1 gray equals 100 centigrade equals 100 rads. Generally, 40 to 50 gray for low volume microscopic disease is needed, while 55 to 65 gray is needed for high volume microscopic disease, and 70 plus gray is needed for gross disease.
Teletherapy, i.e. EBRT, describes radiation given at a distance from a target, where brachytherapy is radiation delivered within the target. 3D conformal RT and IMRT are types of EBRT. IMRT is more advanced, allowing more targeted delivery and less toxicity to surrounding healthy tissue. IMRT is often done with image guidance. SBRT is also a form of EBRT, but it delivers very high doses of focused beam therapy to isolated sites in much fewer fractions.
Brachytherapy uses radioactive decay to deliver therapy. The most common source today is iridium-192. There are various types of applicators, including tandem and ovoids, single-channel vaginal cylinders, and interstitial implants or SIAD devices. This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson. We'd like to thank Dr. Martin Ma, faculty at the University of Washington, who reviewed the content of this episode for accuracy and completeness. Sydney and Maya signing off.